Okay, welcome everybody. My name is Tom Nijnhuis. I'm a nephrologist from the Radboud University Medical Center in Nijmegen. And I will be your webinar host or moderator today. And it is my pleasure to welcome Dr. Francesco Trepiccione, who is a nephrologist and an associate professor at the Department of Nephrology at the University Medical Center of Campania in Naples. And apart from being a clinical nephrologist, he dedicates parts of his time to research into clinical and experimental renal physiology. And I saw that during his training already, he visited several key labs involved in tubular physiology. Eventually, he did his PhD at Aarhus University in Denmark on lithium and the collecting duct. And he did also a postdoc in Paris, where he performed research on the molecular mechanisms regulating sodium and acid-base homeostasis at the distal nephron. But today, Dr. Trepiccione will give a webinar on monogenic forms of hypertension, where he will probably also visit the distal nephron. So we are very happy that he wanted to do this. And Francesco, the floor is yours. Oh, one more thing I would like to add. Please post your questions in the question bar to the right side of your screen, so that we can have a nice discussion afterwards. Thank you.
Thank you very much, Tom, for your kind introduction. I am honored to be part of this faculty of this very successful series of webinars. Actually, this is the second webinar on the monogenic form of hypertension. The first was held by Rosa Vargas at the really beginning of this series. And I will focus mainly on the physiopathology of this monogenic form of hypertension and on the clinical features. So I will briefly remind you why the kidney is so important in blood pressure regulation. And the kidney is able to regulate blood pressure, and also when they meet the salt, the bad guy here, they can really make a very bad movie on the cardiovascular side effect that this can generate. And this relation has been modeled by Guyton at the beginning of the 90s in a very elegant model in which he described that in order to excrete a certain amount of salt and water, the kidney require a equilibrium point of blood pressure. And when we increase the salt and water intake by moving along this curve, in order to cope with this challenging, we need to increase the blood pressure. And then all goes back to the equilibrium point. We can predict that people affected by primary hypertension as this double component. So they have the set point, the equilibrium set point that is right shifted, and also they have environmental factors that make them exposed to high salt intake. While the people with kidney disease, they are on a high level of this equilibrium point, even for relatively low salt and water intake. And among this kidney disease, we can include the monogenic form of hypertension that are associated with an extraordinarily high salt intake. Many attempts have been performed to try to identify the genetic form that stands behind primary hypertension. Around 300 gene variants have been identified, and these are strictly connected with environmental change. So we all know here that primary hypertension is considered multifactorial because of this. However, there are secondary forms of hypertension that can be present all over the ages. As you can see here, likely 80% of secondary form of hypertension in children below 12 years old are due to secondary form. Secondary form does not mean only genetics. Indeed, in this Chinese population, about 1,200 people with hypertension before 30 years old, they were screened for the known gene of monogenic form of hypertension, and they found a prevalence of about 2.4%. So this is why we are having this webinar in a consortium of rare disease. We are speaking about very rare condition according with if we compare with the bulk of hypertension. So the monogenic form of hypertension involved actually the kidney and mainly the distal part of the kidney that is called aldosterone sensitive, and this composed by the distal convolute tubule, the connecting tubule, and the cortical collecting duct, or by alteration in the steroid hormones by the surrenal glands. This lead with the production of aberrant steroids with mineral activity that are able to interact with this part of the nephron, and so determine mainly hypertension with hypokalemia and metabolic alkalosis. I will not speak about this condition here, but this should be always considering in the differential diagnosis with the form that are due to impairment of one of the gene mapping in distal nephron. And usually this differential diagnosis can be done by looking at genital pubular abnormalities that are associated with the form depending by surrenal gland, and of course by the dosage, aberrant dosage of steroids. So basically, we will speak about this condition here, the Gordon syndrome, the apparent mineralocorticoid excess, and Liddle syndrome. This condition has been reported very rarely and is due to a mutation of the mineralocorticoid receptor. Why the distal nephron? The distal nephron is very crucial for the regulation of the blood pressure. One thing is because it's developing behind the macula densa, so downstream the macula densa. So basically means that all the sodium transport here escape the tubular glomerular feedback, so cannot be limited directly by the filtration regulation. And also because in this segment, the sodium chloride reabsorption does not depend uniquely by one transporter or one cell, but different cell type that can work at different times. The main transporter are the NCC that is expressed on the DCT cell, but also another thiazide sensitive transporter, sodium chloride transporter, that is made by the cooperation of these two guys here, the pendrin and the NDCB here, and also the ENaC that is amiloride sensitive. Usually, during condition of normal salt intake, these transporters are shut down, and their contribution to overall sodium transport is very low, but can increase significantly during low salt state or hyperaldosteronism. So basically, you can see here that any alteration in the activity of this can increase the sodium chloride reabsorption, and so the volemia, and so the hypertension. This is a classical nephrocentric view for the pathogenesis of monogenic form of hypertension. Let's start with a clinical case. Here we have a case that has been reported recently of unexpected hyperkalemia in a 17-year-old male that present also high blood pressure, hyperkalemia, and a slight metabolic acidosis. I have some question to you here in order to check that you are still alive and ask you, what would you ask for by having this patient at your clinic? So would you ask for serum creatinine and glucose, pharmacological anamnesis, CT scan of the kidneys, Doppler ultrasound of the renal arteries? Okay, majority of you check for serum creatinine and glucose, of course, because we should exclude that renal failure is present. Also, somebody pharmacological anamnesis, that's good to see if there is some drug. Okay, I don't see the CT scan at this point of the checkout, and Doppler ultrasound is mainly for the stenosis and so of our renal artery, and maybe this is more frequent in young female actually, but also is associated with hypokalemia and metabolic alkalosis usually. Okay, let's see what this guy has. He has a normal GFR actually, so we could exclude that the hypertension is due to renal failure. The renin and aldosterone were lower in the lower normal range, and the renal ultrasound exclude any abnormalities. By checking his clinical history, we could see a dominant inheritance pathway, and so the presence of the hypertension, normal GFR, hyperkalemia, and metabolic acidosis suggest this condition, the Gordon syndrome or familial hyperkalemic hypertension, that is by definition very sensitive to thiazide. So when this therapy was applied, the authors registered a complete recovery both of the blood pressure, potassium, and bicarbonate. Actually, the Gordon syndrome is the specular condition to the Gidelman syndrome. And if Gidelman syndrome is due to loss of function mutation of NCC, the gene involved in the Gordon syndrome regulation are increasing the activity of NCC. And so they are leading to hyperkalemia instead of hypokalemia, metabolic acidosis instead of alkalosis, hypercalciuria instead of hypocalciuria, and low level of renin and aldosterone. The gene involved in the Gordon syndrome are mainly these four: WINK4, WINK1, KELCH3, and KUL3. There is a locus in which that was identified actually very early when this condition was defined, in which the gene, at least a single gene, is still missing. The inheritance pathway is mainly dominant, autosomal dominant, as you can see, 86% patient presenting autosomal dominant inheritance, and the CALCH3, this pie in blue is the dominant gene involved, and this can lead also a recessive form, the CALCH3, while Collin3, Wink1, and Wink4 they have an autosomal dominant inheritance mainly. There is a slight difference in the prevalence of the gene when the diagnosis is made during childhood or adulthood. As you can see, the blue part of the pie that is stand for the Collin3 gene. This is mainly identified in the pediatric population. This is because Collin3 is an ubiquitous gene, not specific or not so much specific for the aldosterone sensitive distal nephron, and so is actually associated to a much more severe phenotype. As recently described in this manuscript, patients with Collin3 or CALCH3 autosomal recessive form, they have a early age of onset of disease, around 5 years old, while all the other gene mutation are detected and diagnosed in the second and third decade of life. This severity is also for potassium level that are higher in the Collin3 patients and bicarbonate level. So a much severe metabolic acidosis can be seen in these patients. Additional clinical features have been associated with Wink4 gene, especially the presence of renal stone and osteoporosis, and Collin3 gene, where people present also fertility problems. But how this 4 gene can interact with NCC? NCC regulation can be modulated by its phosphorylated state, and this phosphorylation state depends mainly by this SPAC kinases that can be regulated upstream by the Wink4 and the K-Wink1, so the kidney-specific Wink1. You can easily see that when Wink4 and Wink1 are mutated, the activation state of NCC is favored, and so sodium transporter in this way is favored. So any mutation in the Wink4, CALCH3 or Collin3 here actually prevent the regulation of Wink4 by its missing ubiquitination. And so this basically means that Wink4 cannot be degraded, and so keep stimulating the NCC through SPAC. And so the activity of the DCT sodium transport is very high. The classical view of pathogenesis of Gordon syndrome is due to an hyperactivation of NCC that leads to hypertension because of increased salt reabsorption and volemia. And this actually is believed to reduce the sodium delivery to the distal tubule, in particular to principal cell. And so by preventing this difference in the membrane potential secondary to ENaC decreased function, prevent potassium and proton secretion, and so determine hyperkalemia and metabolic acidosis. And this was considered confirmed by the fact that by applying thiazide diuretics, you have an increased delivery of salt to the distal nephron, and so you can restore the normality. So treat both hypertension, hyperkalemia, and metabolic acidosis. Actually, during my postdoc in Dominique Ladari lab in Paris, we characterized this model, these mice that recapitulate this form of FHH secondary to mutation in the Wink4. These mice present the same clinical feature of the patients. So they have metabolic acidosis, hyperkalemia. As you can see in the plot here, an increased activity and phosphorylated status of NCC. And so we start to try to dissect the electrolyte abnormalities of these mice by asking whether metabolic acidosis could be due to hyperkalemia. As you all know here, hyperkalemia can impair ammonium metabolism and so impair the secretion of ammonium by the kidney and lead to metabolic acidosis. So we place these mice to a low potassium intake, and we could see that even though kalemia reduced to normal level, metabolic acidosis did not change at all. So we were asking whether these mice, because of the mutation per se, the Wink4 mutation, they had a functional ENaC and proton pump. So we applied an amiloride test to see ENaC activity, and also we stimulate the proton pump function by applying an ammonium chloride load to these mice. And as you can see here in this mice, ENaC activity is sustained, and this is proved by the increased form of the cleaved alpha and gamma ENaC, and ENaC properly responds as in the control to amiloride, both in terms of salt and potassium excretion. And the proton pump is working properly because when it's stimulated by ammonium chloride, you can see that the urinary pH properly decrease and urinary ammonium increase. So these mice properly respond to an acid load. So finally, we postulated that metabolic acidosis could be secondary to a bicarbonate leak that would involve also the B intercalated cell. These cells are equipped with the pendrin, that is an anion exchanger secreting bicarbonate in the lumen and reabsorbing chloride, that can work in tandem with this transporter, sodium transporter, that has still a complex name. It's called sodium dependent chloride bicarbonate exchanger, so NDCB. Basically, these two guys work together by recycling bicarbonate secreted to pendrin. Sodium and chloride can be reabsorbed, and this is thiazide sensitive. So basically mean that when we apply thiazide, this transporter is shut down. To test this hypothesis, we checked by the technique of tubule isolation, the activity of pendrin, and as you can see by the red line here, the activity was increased in these mice, and also the expression of the pendrin positive cell, this B-type intercalated cell, were increased in the FHH mice, suggesting that they are regulated by Wink4. So to strengthen this idea, we ablate in these mice the pendrin expression, And this, as you can see here, increased the bicarbonate level, and so prevented the metabolic acidosis and reduced potassium level to the potassium to the control level, and reinforce and strengthen our hypothesis. So the new model of the pathogenesis of FHH that we proposed in this manuscript is that in addition to NCC hyperactivation that sustain hypertension, mutation in WINK4 is able to stimulate pendrin function, and so to promote bicarbonate leak in the distal nephron. And hyperkalemia was due to a reduction in the expression and function of ROMK, as previously proved by Lifton lab. And when we apply thiazide, the recovery could be due to not only the inhibition of NCC function, but also of pendrin and NDCB. Additional mechanism has been proposed for the cooling form of FHH. In this manuscript, as you can see, a vascular event has been proved by showing that even though the morphology of the vessels has not changed when we knock out or when we introduce a cooling tree mutation selectively in the blood vessels, this blood vessel present an increased expression of this factor that called is ROA, that is a master regulator of the vascular tone. So also a reduced effect of on vascular resistance can be described in cooling tree FHH related mice. Okay, I hope you are still alive, and to check this, I will challenge you with another case report. Here is a classical case report, and that actually this comes from our clinic about a baby with hypokalemia and metabolic alkalosis. Very common condition. The baby was admitted because of failure to thrive. He presented potassium 2.1, chloride 94, and sign of hypercalciuria. So metabolic alkalosis and hypokalemia. What is the most likely diagnosis in your opinion? So we have the multiple choice that include Gordon syndrome, Gitelman syndrome, Bartter syndrome, apparent mineralocorticoid excess, and Liddle syndrome. Okay, the majority of you is for Bartter syndrome or apparent mineralocorticoid excess or Liddle syndrome. These all three are associated with hypokalemia and metabolic alkalosis. Also the Gitelman syndrome, of course, but usually Gitelman syndrome as Liddle syndrome are diagnosed in the second and third decade of life. Gordon syndrome, as we speak before, is associated with metabolic acidosis and hyperkalemia. So this is important because actually is usually a differential diagnosis that can be challenging in these young babies. So to distinguish between apparent mineralocorticoid excess syndrome and Bartter syndrome, because they are only distinguishable by assessing the volume status, and so either by checking the renin and aldosterone level that is very low when the volume status is increased, volemia is increased, or by hypertension, but usually hypertension in this condition is in the AIM condition is diagnosed in the appear actually around 3, 4, 5 years old. So at the beginning, the genetics and the volume status can be the only possibility to discriminate between these two conditions. But this is very important because the mineralocorticoid excess syndrome is associated and leads to CKD. So it is important to have early recognition. To come back to our patient, he was born preterm by consanguineous parents. They were cousins, and he presented very low aldosterone and renin level, and by age of 40 years old he started to present hypertension. He was also affected by nephrocalcinosis, and this can be also of course present in the Bartter syndrome, as you point out. And look at that, the CKD start to be detected by 11 years old, and now is 30 years old and is in stage 4. And the genetic analysis revealed this mutation for the 11 hydroxysteroid or dehydrogenase B2 gene. The clinical feature of apparent mineralocorticoid excess syndrome are characterized by an autosomal recessive inheritance pathway, a failure to thrive and low stature, hypertension, low renin and aldosterone level, hypokalemia and metabolic alkalosis, polyuria, nephrocalcinosis, and you can check this cortisol to cortisone, or checking the ratio on date metabolites that is altered in favor of cortisol, and of course they have an increased cardiovascular risk. The pathogenesis is due to impaired activity of this red guy here, that is an enzyme that in the principal cell, so only in the connecting tubule and cortical collecting duct, is able to metabolize cortisol in cortisone, and so preventing the activity of cortisol on the mineralocorticoids receptor. Cortisol is has much more affinity than aldosterone with the mineralocorticoid receptor. So when in excess, can mimic mineralocorticoid activity. And you can see that since the genetic defect is upstream the mineralocorticoid receptor, in this condition, by applying mineralocorticoids antagonist as spironolactone, eplerenone, will be a very nice therapeutical intervention by preventing both hypertension, hypokalemia, and metabolic alkalosis that otherwise are sustained by INAC hyperactivity. To explain the hypercalciuria and polyuria that can be present in this condition, they are usually due to explained by low RAS level that in turn will reduce calcium reabsorption along the proximal tubule, and so explain hypercalciuria even in presence of alkalosis and not acidosis. Two forms of this syndrome has been identified in relation to the residual enzyme activity. Usually the majority of the form are diagnosed in the infancy before 5 years old, and they are sustained by a very severe and enzyme activity. And the enzyme activity can be tested by checking the urinary level of cortisol and cortisone metabolites. It's not, at least in our clinic, a routine exam, but I think it can be affordable. The AIM2 type instead refers to a condition in which there is a slight residual activity of the enzyme, and these are really tough to discriminate by Liddle syndrome, as we can see later on. So another case is a case of severe hypertension that appeared very early in the life. A 13-year-old boy that present with such a high blood pressure, low potassium, and metabolic alkalosis. As you can see here, the serum potassium is at low limit, is not very low, low renin and low aldosterone activity. Another question for you guys: what would you consider as differential diagnosis? Again, so we have Gordon syndrome, renovascular hypertension, familiar hyperaldosteronism 1 or 2, or this congenital adrenal hyperplasia, apparent mineralocorticoid excess, or Liddle syndrome. Okay, the majority of you consider the Liddle syndrome, but of course familiar hyperaldosteronism, and so the surrenal monogenic form and apparent mineralocorticoid excess should be ruled out. Renovascular hypertension usually is sustained by hyper aldo and high renin, while the patient here has a low renin and a low aldosterone level. So let's check what happened. The steroid profile was normal. This rule out the form dependent by altered genesis of steroids, and the patient was treated for 3 months with spironolactone, but no clinical benefit was found, and this is an adjuvant criterion for Liddle syndrome. And then when the authors apply amiloride, they successfully controlled blood pressure and potassium. And by genetic analysis, the Liddle syndrome was then confirmed. Liddle syndrome is usually autosomal dominant and is associated with hypertension with hypokalemia or normokalemia. So potassium is really not never so severe, let's say. Metabolic alkalosis, and the mineralocorticoid receptor antagonism should be not applied, because they as you see in this case report, did not work and increase cardiovascular risk. While the mineralocorticoid receptor antagonists are not effective in this condition. This is because the increased activity of ENaC is independent by mineralocorticoid receptor stimulation, so it's downstream the place and the target of this drug. So we need something that interacts directly with the ENaC, and so the amiloride and triamterene is the drug of choice in this condition. And how the mutation can affect the ENaC regulation. This has been clearly stated for mutation occurring for beta and gamma ENaC. The majority of these mutations causing Liddle syndrome interfere with this PY motif here in the intracellular loop, and so prevent the NED4 ubiquitination of the transporter, and so it's endocytosis. But there has been also some mutation described for the in the extracellular loop of the ENaC alpha channel that mimic the cleavage status of the ENaC. You all know here that ENaC subunits are activated by the cleavage of this extracellular loop. Some mutation can mimic this cleavage, and so lead to an hyperactive state. However, ENaC is also expressed in other organs like the lung, the vessels, and also the brain. And so in this manuscript, in a model of mice with NED4 knockout, so they can be considered mimicking the Liddle syndrome, you can see that by infusion, high salt in the fourth ventricle in the brain of these mice, the author registered a very severe increase in blood pressure, and this increase was prevented by the application of benzamyl, that is an inhibitor of ENaC. And also additional pathogenic events have been shown to be related to the salt taste. The salt taste on the tongue of the mice, and also because homology in humans is dependent on ENaC expression on the tongue. And as you can see, with the red line, by knockout the ENaC on the tongue, the salt craving of these mice is completely prevented. And this could explain also why Liddle patients are so much attracted by salt intake. So in conclusion of all these three cases that I presented you here of monogenic form of hypertension, this condition can be easily sometimes discriminated when we look at age of onset, for instance, because Liddle syndrome and Gordon syndrome are more occurring in the second and third decade of life, while AIM with is autosomal recessive inheritance in the childhood can be discriminating in this sense. And also before having genetic confirmation, by applying the three different class of drug like spironolactone for the AMI, the amiloride for the Liddle syndrome, and the thiazide for the Gordon syndrome, this can be ex adjuvantibus criteria to discriminate this condition in our patients. By the way, I think, and this is I would like to with this, I would like to leave you. I think it is very important to know the physiopathology of the sodium transport along the nephron to help in the management of this condition. With this, I thank you for your attention, and I will be happy to take any question. Just as a last thing, let me announce the next seminar that will be in January 18 by Michael Maternick, that will speak about the posterior urethral valve disease. Thank you very much for your attention.
Okay, thank you very much, Francesco. I think a beautiful overview of these monogenic hypertensive diseases from the distal nephron. I see that we don't have that much questions yet. That is probably because everybody was paying a lot of attention to your talk. But I have this question, which says, if any patient with AME would develop end-stage renal disease with anuria, could we still prescribe spironolactone? Well, prescribe, yes, I guess. But
yes, I guess we actually we should start to promote this also in the chronic kidney failure, as you know, guys, with the appearance of a new anti-aldosterone drugs as finerenone. So this actually could have also benefit on extra-renal target of aldosterone. This is my personal belief. Usually this is impaired in chronic kidney disease patient because of hyperkalemia, but these guys have hypokalemia. So.
And another question that came in is, what is the reason for the hypomagnesemia in AME?
Hypomagnesemia actually is not reported so frequently, hypomagnesemia in AME, but it could actually be related to proximal tubule, lower proximal tubule uptake, like hypocalciuria, or mainly in the usually in the DCT alteration. But actually we don't have so it is not so frequent, at least in my experience.
Do they also have a tendency to have a hypocalcemia, or because they have hypercalciuria, but
they have hypercalciuria. They have hypercalciuria. In some severe form, they have also hypocalcemia, slight hypocalcemia.
Mm-hmm. And the next question is, could you please explain the pathogenesis of nephrocalcinosis in Liddle's syndrome?
That's a very good question. I don't know if we can ever explain the pathogenesis of nephrocalcinosis in all the tubulopathies, but I don't have clue so far for this. Okay,
so that's a short question, a short answer. Yeah. What I was intrigued
about, I don't know, Tom, if you have you can answer this question, but
no, I'm afraid I don't have the answer as well. So what I was intrigued with is the fact that ENaC has a role in salt taste. Of course, we also know that Gentleman patients tend to have salt craving. What about these Gordon patients, or let's say the transgenic Wink4 mice? Is there anything known on salt intake? Do they actually have less salt intake, which would be physiologically maybe a good idea? Anything known about that?
when we place them in low salt intake, we could see a decrease in blood pressure. This is proved, but we could still we had not a major effect on potassium and metabolic acidosis. If this was the question.
Yeah, and maybe a more a general question. When should we actually look for these, as you say, rare monogenic forms? So I guess high potassium, low potassium could be a clue, right? But are there any other clues? For instance, refractory to certain drugs, or?
Yeah. Refractory hypertension is something, and also, of course, in children or young adults that present hypertension with no other apparently secondary form of hypertension, like obesity, like kidney failure, and after checking, of course, the hormonal status, including the steroids, as I show you, and also if we have information about familial anamnesis, so if there are other cases in the family, and also if the patients look like with short stature, because this is, for example, associated with AMI and also with AMI. Basically, so it's we should exclude other form of hypertension. First of all, related to obesity.
And do you think that genetic diagnosis should be the gold standard here?
I mean, sometimes, especially as I try to present in the clinical reports, in the case report, I mean, the diagnosis can be challenging, and since the genetics screen now is very fast, or should be very fast, this could help in the correct diagnosis. Also in the identification of conditions that are gene negative, so negative to the common gene, and this would help in expanding the knowledge on this condition.
Yeah. Well, there is this rare instances where you think this is Liddle syndrome, then you do the genetic screen, and then you get a variant in a subunit of ENAC, of which the geneticist says, well, it's not a known variant, and we don't know what the significance is.
Exactly.
What do you normally do then?
Actually, of course, in this case, you should check the family, if there is family affected members of the family, and see how it moves, and then we should first of all try to find a solution for the patients. So if these patients actually be very practical, and so if this patient then respond to amiloride, I think we can at least have a strong suspicion that is Liddle syndrome, and then of course we can go to I can say expert center that try to test the mutant in vitro or so on, but this would be like more let's say a scientific approach more than a diagnostic approach. So for the patient, let's try to find the answer in the therapy that we can give now, and so make the diagnosis.
And I guess for situations where there is no, I mean, there are also parts of the world where the genetic diagnosis will not be that easy. Would just testing systematically spironolactone, amiloride, thiazide be a good idea? I see that there are more questions coming in. One of the questions is, what are differentiating points between GRE, so glucocorticoid remedial, I guess it should be an A, and Gordon syndrome?
Actually, this goes in differential diagnosis with the hypokalemic form and associated to metabolic alkalosis. GRE is mainly associated with hypokalemia and metabolic alkalosis. So the differential diagnosis should be with them, and while Gordon is associated with metabolic acidosis and hypertension. And actually, check the steroid levels and all the form of like DOC and all the others, and also check the clinical check of the patients with especially abnormalities in the genital and in the, if we are in the puberal age, the puberal evolution to check, and also if there is hirsutism, because these are mainly also associated to this condition. And then, of course, we can do a try with again with steroids and see if by reducing the pituitary stimulation on the adrenal gland, we can benefit also on the blood pressure.
And there's a question: is there a relationship between Liddle syndrome and essential hypertension?
Actually, this is a very good question. It has many variants of SNPs of ENaC has been associated with hypertension, but these kind of patients are not hypokalemic or do not present metabolic alkalosis and so on. So in view of the pathogenesis on the taste, on the brain central system of blood pressure regulation, and overall systemic activity and function of ENaC, I think this could be this could make the background that could sustain a salt sensitivity, let's say, or let's say a phenotype prone to hypertension. But we cannot absolutely say that all primary hypertension is due to ENaC.
Okay, well, interesting. So in that way, we come back to, let's say, more general hypertension and hypertensive patients, right? I think this was the last question that came in through the question bar in the system. And it's also almost 5 o'clock, so I guess we have to end the session now. Francesco, thank you again for this very nice talk and the very good answers in the discussion. Of course, thanks everybody who was present today. Francesco already told you that there will be a short holiday break, but after that, at the 18th of January, we will have the next ERKNet webinar on posterior urethral valves. And on behalf of the ERKNet Education and Training Task Force, I would like to wish you, of course, a Merry Christmas, a Happy New Year, and all stay safe. Thank you very much. Bye-bye.
Thank you. Bye.
Bye.